Excellent. Well, good afternoon. As Teresa mentioned, my name is Erica Manuel. I'm the CEO and Executive Director of the Institute for Local Government. And we are a proud co-sponsor of today's sort of presentation slash webinar and meeting. And we're a relatively new partner of the association. And it's because of our alignment, right, with some of the same work that you do. ILG is also a nonprofit. We're focused statewide, but we work with all the cities, counties, and special districts in the state. We're affiliated with the League of California Cities, the State Association of Counties, and the Special Districts Association. And what we love is when there are issue areas that cross those jurisdiction types, and we know that mental and behavioral health absolutely is in that bucket. And so it's been our pleasure to kind of work very closely with Teresa over the last few weeks to understand how that alignment can even grow, and our partnerships may continue to grow as we think about the issues that are impacting certainly your jurisdiction types, but also the ones that we're also working with. And when you think about issues that we deal with, which are tied to leadership, governance, engagement, sustainability, and workforce development, we know that there are some opportunities for us to transition our thinking and certainly expand our collaboration. And so we are very excited to co-sponsor today, and we'll hopefully continue to provide shared education for our jurisdictions with the information that you all have and vice versa. So thank you for allowing us to be on the line today.
Thank you so much. We really appreciate the partnership. All right, so let's get started with behavioral health in California, past, present, and future. We in California, like many states in the U.S., in the past, institutionalization was the norm. We have a picture here of Napa State Hospital with the name at that time in 1875 when they chose to build it. They called it Napa Asylum for the Insane. And then it became renamed in 1924 to Napa State Hospital. And at that time, the term insanity became out and mental illness became the term to use. And we've seen lots of changes in terms of terminology, and we're still growing up to understand, just first-person language in terms of speaking about people with mental illness, individuals with schizophrenia, people with bipolar, people with substance use disorders, people with addiction, instead of labeling people schizophrenic or addict. Those are things that we try to discourage and try to teach. And so as early as 1924, that was an issue as well. I'm going to, let me just check the chat and make sure everything is good. Okay. If you want to turn on closed captions, you should be able to at the bottom of your screen. I think that each user has that ability. All right, so let's go to the next. All right, so institutionalization to community-based services. We've seen a lot of effort toward that over the years. There was some major efforts in 1957 when the California legislators created the Short Doyle program, and that shifted some responsibilities and ensured that mental health services would be used in a system that's county operated with county or contract providers. And right now in California, I think probably it was because of that time period, we have 59 mental and behavioral health agencies in California. 57 of them are county. I know we have 58 counties in California. 2 of the counties have combined Sutter and Yuba, so they have one behavioral mental health plan. And then also Berkeley has a plan, and Tri-Cities, which is 3 cities that are in the LA area, they started a plan as well. So those are mental health plans that started in 1957. In 1971, the California legislature added short dwell community mental health services into the scope of Medi-Cal benefits, so that enabled counties to obtain federal matching funds on their costs. So they were using the federal funding from Medicaid, which in California we call Medi-Cal. And then in 1975, many patients were transferred into what was called community placement facilities, or simply discharged from state institutions. And we saw two systems unfold during that time. So for people with intellectual and developmental disabilities who were in institutions, they were put into developmental centers. So it was still pretty institutional, and then there was a regional center system created as well with resources. For people with mental illness, they were supposed to be placed in community. It didn't go as well as hoped. I think that we started seeing people even walk off the grounds of some of the institutions at that time without a place to go. So we did not roll that out well, and we're still working on that. Over the years, we've had shifts that we call realignments. So the state had responsibilities and funding that it administered, and decided that it was in the interests of the local communities to administer that funding themselves. So the funding and the responsibilities were realigned both in 1991, that was for health, mental health and social services. And then in 2011, for a number of services, criminal justice realignment is what it was called. And it included funding for court security, adult offenders, parolees, public safety grants, mental health services, substance use, and CalWorks, let's see, child welfare programs, and adult protective services. And so these realignments draw funding from a percentage of our state's sales tax rate and vehicle license fee revenue. And I'll go through the funding a little bit later on another slide. All right, we've gotten to the Mental Health Services Act. So in 2004, we had a proposition on our ballot, and the voters approved what's called the Mental Health Services Act, Proposition 63. And it brought funding from the wealthiest people in California. So people that have an income of $1 million or more were taxed 1% on that income. So that went into what's called the Mental Health Services Fund. And the purpose of this was to transform the system from one that was really considered fail first to one that would promote intervention, treatment, and recovery, including, prevention. So we were seeing people accessing services only when they were in crisis or at really high, they were at really high levels, they were being hospitalized. Sometimes they were incarcerated. Sometimes they were homeless. So this was an attempt to really reshape the system. So the Mental Health Services Act, I'm going to review this a little bit. So we're at a time that we're shifting because of Proposition 1 that just passed on the California ballot. We are shifting from what I'm going to go through right now, the Mental Health Services Act, to what's called the Behavioral Health Services Act. So these slides, I think it's 2 or 3 slides that I have on the Mental Health Services Act. Just so you understand where we're at today, we haven't implemented Proposition 1 yet, but this is what we've been working with since 2004. So The Mental Health Services Act is administered through the 59 behavioral health agencies. They have certain requirements, and I think the staff in these behavioral health agencies or mental health agencies are some of the smartest people I know. They jump through hoops to make the different funding mechanisms happen. So with the Mental Health Services Act, there were different percentages of funding that were required to go toward different types of services or initiatives. At the top here, we have innovation. 5% was to learn something. So the counties were to create plans. Usually they were 3 to 5 year plans, depending on the size of the county and their needs. And they were supposed to be learning from those innovation plans. Sometimes they would create new programs, or they would do research, or they would work on some type of technology in order to make their system work better. Lots of different innovative ideas came from that, and many of them were put into other programs in the future. 19% was to go to prevention and early intervention, and then 76% to everything else. So community services and supports, that's the bulk of the programs. And a lot of the community services and supports were put toward what was called full service partnerships, which was a whatever it takes approach to mental health. So people would have other social services braided into their offerings. They could have vocational services to find employment. They could have housing as part of their offerings. And this fund could actually even help fund some of the housing or facilities. It wasn't enough to do that. It needed, a lot of it did go to services. And then there was the possibility, if the counties chose to put funding into like capital facilities and technological needs, workforce education and training. Oftentimes, some of the smaller counties would get together for regional partnerships for workforce education and training. And then they had the ability to set some money aside for a prudent reserve account, because they didn't know 1 year to the next how much funding they would get through the Mental Health Services Act, since it's based on income tax. All right, so here's a slide showing the different components that make up the mental health funding in the communities today. So we have the Mental Health Services Act, which will change in a year, in less than a year, actually. Parts of it will be implemented. So Mental Health Services Act, approximately 25% of the spending in a county. Realignment from 2011, about 17%. Realignment from 1991, about 14%. And then those funding, the MHSA and the realignments, and then some other like block grants make up the funding outside of what the Medi-Cal matching would be. So the Medi-Cal matching requires, so Medi-Cal is that federal funding. It requires some local funding in order to match it. So that was a really good way to increase the funding that came from the federal government to use the Mental Health Services Act funding toward that. And then counties also use other funding like realignment. Okay, so we've gotten to Proposition 1 now. So it was on the March ballot. Some of you may have followed it closely. There was a very, very close election or a ballot on this. And it wasn't for, I think, maybe a few weeks after the election that we found out that the bond passed. And the behavioral health, or that the proposition passed. So that created the $6.38 billion bond called the Infrastructure Bond Act, and then the Behavioral Health Services Act. So it changed California's law and our welfare institution code to update it so that, and I'll go through the changes. Let's start with the bond though. So the bond has different components to it. First, treatment and residential, and that has two areas. So $2.893 billion for grants for behavioral health treatment and residential settings. And it's building on the success of what we've had roll out over the last 2 or 3 years. It's called the Behavioral Health Continuum Infrastructure Program. So California's put a lot of funding into behavioral health infrastructure and wanted to continue that model. So we will see that funding go toward that. And $1.5 billion to be awarded only to counties, cities, and tribal entities for grant for behavioral health treatment in residential settings. So both of these are toward behavioral health treatment in residential settings. Although the 2.893 is a little more open, so nonprofits and other agencies could be applying for these grants. And the 1.5 billion is for counties, cities, and tribal entities. All right, and then the other section is the housing. And give me a moment because we have a little Zoom issue here. All right, so with the housing, there's 1.065 billion for housing investments for veterans who are at risk of homelessness, experiencing homelessness, or experiencing chronic homelessness and have behavioral health needs. Our administration had really high numbers for veterans with risk of homelessness and within this category. So quite a bit was put toward that. And then 922 million worth of investments for Californians who are not specifically for veterans, who are at risk of homelessness, experiencing homelessness, or experiencing chronic homelessness, and have behavioral health needs as well. Okay, there's a question in the room, but if you have a mic. Okay, let's get you a mic. All right, this is Christine Hatia from Napa County Mental Health Board.
Okay, does that make a difference? Yes. Okay, I was just wondering, the residential treatment, the treatment and residential are specifically grants. The housing, are those also grant opportunities, or is there some other way that that's being distributed?
I would expect this all to go through grant process. So we'll probably start seeing the applications. Yes, there's another question in the room.
Hi, Carol DuPay from Orange County. The treatment in residential, do we have any idea what the parameters are for this? In other words, what kind of requirements are we talking about? Really, that's what so I'm specifically looking at board and care for older adults who have mental health conditions. And in my county, in Orange County, we don't have any. So that's what I'm wondering about. What are the requirements?
Right. Yes, I think it does cover the board and care. There were a number. It's between the two, treatment and residential and housing. So, I think between those two, there's a lot of opportunity to cover both board and care and just kind of the whole continuum of housing and care that needs to be there. I don't have, I was just looking at my, my list here from my presentation. It's not on here, but we do have a link to our website, where, Health and Human Services just put together a presentation, so you can look at that and see the listing of the identified, categories and it's very broad. Yes.
Oh, broad. Okay, so that would include like ADA housing as well. American Disabilities Act.
I think anything that goes in probably has to abide by the ADA, but I don't know the specifics on that.
I doubt that everything has to abide by ADA,
Okay,
but at any rate.
okay. The new construction, right? That's a good point.
Thank you. Teresa, I was just going to mention that Boarding Cares also has community care licensing, separate budget. And the B-CHIP, if you just search it, all the information will come up because in multiple rounds. But it does sound like the state is going to get that bond money out fast. So it looks like it's going to be probably an extension of Project Homekey. That's sort of what those meetings have been saying, right? That's what I took away from the meeting.
All right, thank you. So we're going to move on to the Behavioral Health Services Act now. And there were 6 key reforms that we'll talk about briefly, and I have a couple of slides on 2 of these. So we're of course renaming the MHSA, which is the Mental Health Services Act, to the Behavioral Health Services Act. We're broadening the target population, so it includes people with debilitating substance use disorders. And I'll stop there just to explain that in 2004, when the Proposition 63 for the Mental Health Services Act was being considered, there just wasn't the public will or understanding of substance use disorder. There was just a lot of stigma attached to that, and I think maybe we've grown because the voters were ready to say, yes, we understand that's a brain illness, and we do want that included. Then the third item here is focus on the most vulnerable and most at risk, including children and youth. So there really is a focus on people who have the most significant needs. And you can see that in terms of needs for housing, but also there seems to be more of an emphasis on serving people with serious mental illness or that need early intervention. But then there's also still prevention. It's just shifted more to the state level. There's number 4, some increased measures for fiscal accountability and updates to county spending and revision of the county processes. There will be more repercussions. I think in the past, maybe counties may have been outside of the guidelines, but this new change to Welfare and Institution Code really shows some teeth in terms of pulling funding away if the counties aren't stepping up to the model that they're signing up for. And I see a question. Go ahead. Jay Onedera. Okay, you're on mute. All right, we'll move on. The next item is an update to the local categorical funding buckets, and I'll go through that in just a moment. And then increase transparency and accountability, which is also on another slide. All right, so the funding buckets. So 30% are for housing interventions. That's for all ages, children, families, youth, adults, older adults, all living with serious mental illness. For children, we call that serious emotional disturbance and or substance use disorder, who are experiencing homelessness or at risk of homelessness. And this funding can be used for rental subsidies, operating subsidies, including for behavioral health settings built through the general obligation bond, the bond that we just talked about. And then shared and family housing, and then the capital and non-federal share of transitional rent. And I should mention, there's been some changes in terms of California's ability to collect Medi-Cal funding. And it kind of parallels some of the buckets here in order to leverage this Behavioral Health Services Act funding in order to match it with federal funding. And then 35% is for full service partnership programs. I mentioned that earlier. That's the whatever it takes approach. And we see really good outcomes in counties who've implemented these programs. And I think all of the counties have. Most of them are on our website. We have a performance page for each of the counties, and it will show you that we're seeing reduced hospitalization, we're seeing reduced incarceration or arrests, we're seeing increased wellness, which is what we want to see. We're seeing increased employment, just overall, the full service partnerships really treat the whole person. And once people are in those programs, we really see a significant improvement in their lives and for their families' lives and for the community as well. Then 35% are for behavioral health services and supports, including early intervention, outreach and engagement, workforce education and training. And actually, with the workforce, the state also is going to be using some of the funding. They're taking 3% of the funding toward workforce initiatives as well, and also leveraging some federal funding for that too. So we'll really be trying to increase the workforce throughout California. We know that there's a shortage and lots of vacancies, and that's a big issue with trying to scale programs. Okay. Let's see, so that 35% to finish that, it can also go through to capital facilities, technological needs, and also innovative pilots and projects. And so there will be community planning processes in order to decide how that funding will be spent. I'll talk a little more about that. All right. This is the statewide funding buckets. So our state takes some of that behavioral health services funding, and they will be administering it. We will probably see some of this as grant funding as well, or different scholarship and grant initiatives in order to do different types of programs. Like for prevention, it's showing 4% of total funding. That will be, just major communications probably, but also we know there are a lot of programs, even local community programs that work on prevention. So I would expect to see some grants there. We haven't seen, the actual administration of this yet, but in a state as large as California, it's going to probably be both. We'll see some statewide initiatives, but we'll also see, finding where the successes are and increasing the funding for those types of prevention programs locally. And then workforce, 3% of the funding in order to expand. They say culturally competent. A lot of advocates don't like the term competent, so culturally relevant, or programs that take into account ethnicity, culture, race, LGBTQ, age for children or for adults, people that are coming out of incarceration. A lot of thought needs to go into the workforce development in order to find people with the experience and background that can be helpful to somebody that's coming out of mental health crisis, or maybe to help them prevent mental health or a substance use crisis. And stay well. So then the third area is statewide oversight and monitoring. That's 3% of total funding. And I should say our association, Cal BHPC, has advocated over the last few years to increase performance outcome measures. So we're tracking this closely and would like to see, real increase in that. And that's something that was promised through this Proposition 1. So we hope to see more standardization, more identification of where the successes are, where the barriers and challenges are in terms of the programs. And just overall, we want to see better life outcomes for people that receive behavioral health services in California. There's also some funding here that will be administered through the Behavioral Health Services Act Innovation Partnership Fund. That will be done through the Behavioral Health Services Oversight and Accountability Commission. There's a commission here in California that has done quite a bit of administering of this type of contracts in order to do initiatives to fill a gap or, address a challenge and increase successful programs. So usually you'll see these types of initiatives start with maybe some pilot projects, and then they'll create policy papers and, try to advocate with our legislature in order to, do what we need to do in order to increase these types of programs that work. All right, so increased transparency and accountability. There was quite a bit of thought that went into this area. There is a new county integrated plan for behavioral health services and outcomes. That's the new name for what we used to just call the annual update or the MHSA 3-year plan. So it's going to be called the County Integrated Plan for Behavioral Health Services and Outcomes. And that will include all the behavioral health funding and services and Medi-Cal. So this will be a change where everything will be shown together. So we'll get an idea of how the funding flows within the counties and how well they're able to leverage. And keep in mind, some of these small counties in California, this is difficult to leverage the Medi-Cal funding sometimes. We have a very diverse state in terms of the size of our counties, with LA County at over 10 million people and Alpine County at over 1,000 people. So this will be administered differently in different counties. There will be a new county behavioral health outcomes, accountability, and transparency report, which will help our local boards and commissions in their advisory duties for sure, in order to find where are the challenges, where are the difficulties, and how is the county really spending the money. So we will see just more of that kind of information locally as well as statewide. Let's see, I won't go through all of these, but let's see, number 4 talks about the Behavioral Health Services Act Revenue Stability Work Group. That will hopefully address some of the volatility of the funding. It's difficult for counties to know how much they should be scaling their programs if they don't know how much funding they're going to get the next year. So having a decent amount of money set aside in the prudent reserve, but also finding ways to make that funding less volatile. I think that the Legislative Analyst's Office has some ideas. Let's see, and number 6 is parity between commercial and Medi-Cal. So that is something that we've really struggled with, is just having access to behavioral health services through commercial plans, through private insurance. And we need to increase the visibility of the data so we can understand what's happening there, and really ask the private insurers and private plans to step up, both with their workforce and providers, but also their ability to pay, so that we, when we need services, we don't have to go into mental health crisis or substance use crisis before we receive services. That we would be receiving services with parity to any kind of health service. All right, I'm going to move to the next slide. All right, this has the Mental Health Services Act, stakeholder community engagement on the left side, and then it has the Behavioral Health Services Act on the right side. So what we have today is on the left. So the stakeholder involvement is on mental health policy, program planning and implementation. We do monitoring, and there's quality improvement committees, which will have stakeholders on them alongside behavioral health staff. And there's some evaluation that takes place within those quality improvement committees. We try to do some evaluation as behavioral health boards. It varies county to county depending on what kind of data we see. And then, you know, we were able to see what the budget allocations are in the Mental Health Services Act plans and updates annually. There are big requirements around the Mental Health Services Act right now, in terms of the requirements for who would participate in any kind of planning processes in the counties. So any participation should include communities that are unserved and underserved, people with serious mental illness or serious emotional disturbance and their families, providers of mental health, physical health, and social services agencies, educators, and law enforcement. That's just a partial listing. Veterans should be on there as well, older adults. So there's quite a robust ask right now for the counties. And I think, you know, some of the counties do it well. They really do reach out to stakeholders in different ways, meeting them where they are and where they're comfortable. And that does help drum up more workforce, more access, more visibility, and more culturally competent programs when that happens. So that will change a bit. And at the bottom of this slide, we have something called a 30-day comment period that's noted. So when a plan is created, it should identify what the planning process was, and then also identify all of the different components within the Mental Health Services Act in terms of what kind of programs is the funding going to, and what were the performance outcomes for those programs that happened in the last fiscal year. So that happens now, where we will have the county put together a draft plan, and once they put it out publicly and then announce it and put it on their website, 30 days later, the behavioral health or the mental health or behavioral health board or commission will have usually their monthly meeting, and they will have the MHSA hearing during that meeting, where they will you know, just review what kind of comments were in that report or in that plan. And usually at that point, the plan's pretty ready to go. It's being signed off by the behavioral health director. The board of supervisors need to adopt it, and then it goes to the state in order for the funding to flow to the counties. So I think that process may be very similar in the future. One thing to keep in mind that for the local mental and behavioral health boards and commissions during that process, they should be actually making recommendations on the plans and updates the rest of the year, not at that final 30-day period, but after that plan is adopted, that's their time to start making recommendations. And if a local board or commission makes a recommendation on the Mental Health Services Act or what will become the Behavioral Health Services Act, the county behavioral health agency must respond either by implementing their recommendations or by explaining to the board of supervisors or the local governing body why they didn't implement those recommendations that were voted on by the Behavioral Health Commission and supported by the Behavioral Health Commission. They must explain why they didn't implement them both to the Board of Supervisors and to California's Department of Healthcare Services. So there's some accountability there, and it's nice to see that there is some teeth in terms of the boards and commissions when they make recommendations. So the difference for the Behavioral Health Services Act, we've put in bold just some changes in terms of incorporating substance use disorder, more stakeholder involvement on workforce, which is really well needed, and health equity as well. All right, there's a question. Let's get a microphone. Hello. Who is it? Oh, okay. Carol, go ahead.
Hi, this is Carol DuPay from Orange County. My question has to do with, you were just talking about in terms of the accountability, if a recommendation is not acted on. I guess I'm wondering, first of all, how long of a period do they have to say why they're not going to act on something? And then second, is there any recourse if the board feels like, or the commission feels like the reason for not acting, they have some issue with why they're not acting on the recommendation? So that's a two-part question.
Yes, okay. So for the first part, the county is required to do an annual report to the Board of Supervisors and Department of Healthcare Services that includes those recommendations that were made that were not implemented, and an explanation, both a summary of what the recommendation was and why they didn't implement them. So that's the first answer.
So it could go for a
date,
year
it
before
just
they,
says annually.
so it could go a year before they actually
That's true.
respond to
They may be doing the plan, they're gonna start on the next plan after they get the plan adopted, they start on their next plan. So
Right.
yeah, you may not see it, but maybe they'll implement it instead. But if they don't, they have to explain why they didn't do it.
but it could still go for a year before
Right.
we find anything out. And so that our recourse or our regress is not very good.
But keep in mind, you're an advisory committee, so you do the best you can and keep advising. Advise again, keep that topic in front of them. They need to have the stakeholders like you asking for these things. Otherwise, we know it won't happen.
Right.
But they do the best they can. Hopefully, we want to give them that credit. I think some of the behavioral health agencies are the smartest people I know. And they're trying to make the funding work. They're trying to find the contractors to fill the positions. They
Understood.
just try to do it.
I understand that.
Yeah.
All right,
And
thank
then
you.
was there another?
Yeah, the second part was, what if the board is uncomfortable or with the rationale presented for not doing something, what What recourse does the board have? Recommend it again?
Recommend again, just keep recommending, you know. The board can also, when you're doing advisory work, if you have found an issue that you really feel strongly about, you can create an issue brief on it. You can take that issue brief to the Board of Supervisors. You can take it to other commissions. You know, you could take it to other, you know, housing nonprofits. You can use that type of information and work together if you've made decisions as a board. Okay, yeah. It's a system where, you know, there has to be a lot of collaboration, especially on funding. Yeah.
This
there's
is
another
Carla.
question. Go
Carla
ahead.
Perez with Orange County. I just wanted to clarify, just kind of piggybacking on Carol's question. Is that for substantive recommendations only, or just formal recommendations that are made throughout the year?
It has to be what we call substantive, and that would be the board has voted on them. So it needs to be on their agenda that they're voting on something that's MHSA or BHSA. And then if they supported it through a vote, then it's substantive. All right, quick question.
Yeah, this is Steve
Go ahead.
McNally from Orange County. I just want to clarify too, because Carol, I think also, while she didn't say it, is talking a little bit about letters of recommendations that we've made to our Board of Supervisors, sort of like the Behavioral Planning Council, where the CAC didn't reply back to them. And what do you do? The other thing I want to put on the table, though, for future discussion is the reality of community planning and how much stakeholder involvement is and how quickly the boards actually see what's in an MHSA plan. We never see any of it before the comment period opens.
Okay, so we're going to move into specific welfare and institution code for the local boards and commissions. Right now in California, we have over 50% of our boards and commissions are behavioral health boards and commissions. And then less than 50% are just mental health boards and commissions right now. With this shift, they will all become behavioral health boards and commissions. That doesn't mean they have to take that as their name, but they have to take on the responsibilities of a behavioral health board or commission. And that would incorporate substance use and substance misuse. So there's some changes in the bylaws for every county. You're going to need to update your bylaws. And there are two different areas of membership that need to be updated as well. All of this is effective January 1st, 2025. So you can start working on it right now. First, there's a youth membership requirement. And that would be a youth member would be somebody that's 25 years of age or younger who is either a consumer or a family member of a consumer. And we define the term consumer to be somebody with lived experience. So they would have lived experience either of mental illness, and that means they have received services, doesn't have to be public services. They just need to receive services for mental illness sometime in the past. Currently, it doesn't have to be at the current time, but they had to have services. And so it's either a family member, a consumer, or a person with lived experience. Oh, and the other part of the lived experience is of substance use disorder or substance misuse. Okay, we just had a question in the room in terms of substance use with treatment. I will have to get back to you on that. I don't remember reading with treatment for that. And it's difficult to find consumer definition in the welfare and institution code. So I'm going off of the one that I saw for mental illness. So I can get back to you on, but I would think for the most part, it would be somebody that has had treatment, because they would be somebody that you would decide to recommend to the Board of Supervisors to put on your board. There's a requirement for a staff member from a local education agency. So that could be anybody, you know, it could be administration within a local education agency. It could be a teacher, a principal, a counselor, school psychologist, any staff member. You must have one on your board or commission. And then, of course, the word mental is changed to behavioral health, or to behavioral, and substance use disorder is added in the duties. So you'll be advising on both. So we have a document, this presentation is on our website, and we will put this chat so you can get to it. And I think we've emailed you a link to the materials for most of you. And we will, so what we've done is put all of this together into the one document that gives you all of the welfare institution code for the boards and commissions. That includes expenses, it includes membership, it includes your requirements for your bylaws and your duties. And then the last page of this document will give you those 3 updates that I just went over that are because of the Behavioral Health Services Act. So this is just a short piece on, you know, what the timeline is for the bond funding. It's starting now, summer of 2024, that we should start seeing requests for application. And then for the integrated plan, for the new behavioral health services integrated plans, those will be required in July of 2026. Well, it says go live July of 2026. So I would think they need to be, these plans need to be in draft form at least 30 days before that, right? Probably before that. All right, and we have also on our website a Proposition 1 summary. So it just goes through the different components that I described today. And then we have links to more documents as well if you want to learn more about the Behavioral Health Services Act. And we'll be updating our website. We have some modules right now that are just like short 15-minute check your understanding trainings on the Mental Health Services Act. So we're in the process of updating those so that you can check your understanding of the Behavioral Health Services Act. And then my final, I think this may be, yeah, this is the final slide. This is a link to a document on the behavioral health continuum. There's so many pieces to the continuum, and we want you to just get an understanding of what is the scope of this. You know, what are the main engagement tools? What is included in comprehensive community services, and then what kind of interagency collaboration needs to take place. And then we also on that document have links to a lot of different issue briefs that are really specific to certain areas that have been identified throughout the last few years by the counties as major points that need to be addressed, or areas that we've seen a lot of successes, and we're calling out some of the successes so other counties can consider those for their solutions. So I want to thank you all for joining us today. It is 2:30, and we're going to move on to the next portion of the agenda. And I know a lot of folks just signed on for the 1 hour. So just want to thank you, appreciate your participation today, and don't hesitate to reach out with questions, and go to our website, calbhbc.org, to the meetings page, and that's where the link is for this, for all the materials for today. So thank you all.